One last question about triplet therapy. For those of us who are using it at front for our patients without an actionable mutation, get this question a lot. What do you do next? Off of a clinical trial, maybe we can spend 2 minutes on this. What are people's perspective, insight on what the best options are for these patients after, because you're giving them all the active therapies up front, and when patients' tumors begin to progress, we're left with few options outside of clinical trials. So off of a clinical trial, because I think we all want these patients on trials, we need these questions answered, but off a clinical trial, what's the best option for these patients?
Right now, Ben, chemotherapy is what we end up offering these patients. Docetaxel, which has been salvage therapy for a long time now, continues to be the cornerstone. Now, the ramucirumab docetaxel combination had modest survival advantage over using docetaxel alone. So in a patient who's appropriate for the combination therapy, that would be an appropriate recommendation. Otherwise, docetaxel alone. But we all agree that that's not going to give us the kind of results that our patients are looking for and for what we want for our patients. So we invariably have to go back and ask the question, how can we develop more effective treatment options? At this meeting, there are some studies that are being reported that are early. This morning, we saw Matt Hellman present the results of a small study, about 70 patients, combining an HDAC inhibitor, entinostat, with pembrolizumab in patients who progressed on immunotherapy. Now, the response rate were not great, about 10%, but the disease stabilization was seen in another 50% of the patients. So that provides some suggestion that these kind of combination approaches might result in better outcomes for this patient group.
Epigenetic strategies, I think, are going to make their way in.
Probably, don't forget also that most of these patients, so they have a maintenance with an immune treatment alone. Generally, they receive only 4 cycles with a platinum salt. So we should think also to try to reintroduce a platinum salt, because some patients might receive 6 months, 1 year, 2 years an immune treatment, and so they are in good performance status. And in some of these patients, just the fact to reintroduce a platinum salt, cisplatin, with another drug or carboplatin, paclitaxel weekly, might bring a huge benefit in our experiences. So that's why we might still be aggressive in this population when they progress beyond immune treatment.
Interestingly, there are 2 series now that will be updated, I think, early next year, showing that chemo after checkpoint might be of particular interest. Of course, it's retrospective series, but showing that this monotherapy, vinorelbine, docetaxel, gemcitabine, would give rise to 30-35% response rate as compared to the usual 7. So there's really a room to give, again, if it's frustrating, but to re-challenge chemo, even if it's docetaxel. But we're still not at the point where we should try to manipulate what we have. I've seen colleagues giving Ipi/Nivo, adding Bev, or I think we need data, and we need really to move into clinical trials, all the cytokine story, which will be presented again. So there might be salvage therapy using immunos that will come, and we need to document it before testing it in the patients with our data.